Okay, good evening, friends. I welcome to you all. I welcome you all to this another YouTube session on a very interesting topic. Uh, Today's topic is about the oral potentially malignant disorders. Oral potentially malignant disorders. So this topic is actually it is a very conventional topic. All of us know that about pre-malignant lesions, pre-malignant conditions. All of us have heard about this. In oral cavity, we have some pre-malignant lesions, we have some pre-malignant conditions. Lesion, for example, leukoplakia, erythroplakia, pre-malignant condition like oral submucous fibrosis. So we have two divisions actually: pre-malignant lesions, pre-malignant conditions. Pre-malignant conditions. But a WHO, World Health Organization, in the year 2007, they formed one working group, and they told that rather dividing into pre-malignant lesions and pre-malignant conditions, we will make one common term that they called it as OPMD, oral potentially malignant disorders. So this OPMD is one common term which includes both pre-malignant lesions and pre-malignant conditions. Okay, now let us go into the details of that. What exactly is OPMD? It is a group of oral mucosal lesions with increased risk of malignant transformation. So it is not one lesion, it is a group. What is the problem in those lesions? In those lesions, the problem is that they have increased risk of malignant transformation. That means the problem here is that those lesions can develop into cancer. Those are called as oral potentially malignant disorders. These oral potentially malignant disorders, if you see, there are many, like leukoplakia is one, erythroplakia, erythroleukoplakia, oral lichen planus, oral submucous fibrosis. There are many. I've given some examples here. All these, like syphilitic glossitis, discoid lupus erythematosus, dyskeratosis congenita. There are so many oral lesions which have increased risk for cancer development. Those lesions are called as potentially malignant disorders. In 2007, WHO has defined these lesions. The definition says that any oral mucosal abnormality that is associated with statistically increased risk of developing oral cancer. The term statistically increased, that is important. It should be statistically significant. It should not be like 1,000 cases are there, okay, or I'm sorry, if I take a big number, 10,000, 1 lakh cases are there. Out of that, only one patient is developing cancer. That is not statistically significant. So WHO tells that any oral mucosal abnormality that is associated with significantly increased risk of developing oral cancer, then you should call this as OPMD, oral potentially malignant disorder. So now the previous terms, pre-malignant lesion, pre-malignant condition, are obsolete. They are not used. Now, let us go into little more details of this. What is the epidemiology and risk factors for these? The most important risk factor is tobacco and alcohol. Remember, tobacco is the main culprit for oral cancer. Now comes the question, is alcohol independently responsible for oral cancer? No. Alcohol acts as a synergistic effect. That means if there are two patients, one patient is only tobacco chewer, another patient is a tobacco chewer as well as alcoholic consumer. The patient B, second patient, is at a higher risk to develop oral cancer. Why? Because the alcohol has got a synergistic effect with tobacco. Okay, exactly. If you see what the alcohol will do, if you go little more detail, what the alcohol will do, they say that alcohol increases the mucosal permeability of these carcinogens. What the tobacco will release the carcinogens, they have to enter into the mucosa, right? Then they will enter into the body. So that mucosal permeability, that mucosal entry is facilitated or increased by this alcohol. So that is the broad way how an alcohol increases the effect of tobacco. If we go genetic level, this is broad. Rather than broad, I can say morphological level. What happens at genetic level, genome level? These tobacco and alcohol consumption, they will alter the genetic stability of the keratinocytes. How they will alter? By causing alteration or defect in important genes. What are those genes? Notch1, P53 gene, EGFR. What is EGFR? Epidermal growth factor receptor. CDKN2A. CDK stands for cyclin dependent kinase. N2A. STAT3. All these are some genes. Please remember these 5 genes. This tobacco consumption will alter these genes. Thereby, the patient can develop oral cancer or pre-malignant lesions. So the important you should remember is the relation between the tobacco and the genes. What are the various genes? You have to remember Notch1, P53, EGFR, CDKN2A and STAT3. Okay. Now moving on to what happens with HPV. Yes. Nowadays, a new trend has started or has developed, not started, has developed. Patients, that is oral cancer patients, come and report to you and they say that they don't have any history of tobacco consumption, but still they have developed oral cancer. So previously, before the advent of role of this HPV, human papilloma virus, these cases were very difficult to treat. Why? There is no etiology. See, treatment is possible only once you establish the etiology. In this case, etiology was not established at all. But later they found out that there is a virus called as human papilloma virus, HPV. Particularly remember the 2 HPV. Number are very important. I'm sorry. HPV 1618. Please remember these 2 numbers. HPV 1618. These 2 are called as high risk HPV. What are these going to cause? These are high risk HPV, means these are nothing but these are oncogenic HPV. They can cause oral precancer. They can cause oral cancer. Okay, so that is why HPV 16-18 are considered to be the oncogenic viruses. Next, aracanut, all of us know that is very common. Aracanut consumption or betel nut consumption is very common, especially in Asia and in India particularly. Okay, exactly how aracanut will cause carcinogenesis is not that clear, but still what they say, they have proposed certain mechanisms. The aracanut or the betel nut consumption causes chronic inflammation. It can cause direct DNA damage. It can inhibit tumor suppressor genes. It can cause repression of DNA repair. Repression means suppression. See, if DNA is damaged, our body has got one mechanism for called as DNA repair. But if that repair itself is suppressed, what will happen? DNA damage will remain, and if there is anything damaged in our body, that can result in cancer. So DNA damage repair is suppressed. Okay, or sometimes stem cells might be affected. So aracanut can cause oral cancer by many mechanisms. It could be chronic inflammation, it could be direct DNA damage, it could be suppression or inhibition of tumor suppressor genes, it could be suppression of the DNA repair, or it can involve stem cells. That is, these are the various mechanisms how an aracanut can cause oral cancer. So we have seen broadly about the etiopathogenesis, or I'm not exactly etiopathogenesis, risk factors for oral cancer and precancer. Now, what is the flow chart? How to identify? For example, if an oral lesion is there, and if the lesion resolves with or without therapy, you give treatment or you don't give treatment. If the lesion resolves, then what is your treatment? What you have to do? You have to just follow up the patient. You have to just follow up the patient. In case if the lesion persists, it doesn't resolve on its own, then you need to do biopsy. After biopsy, you need to find out the histology. What exactly is this lesion? Is this dysplasia? If it is dysplasia, whether it is mild dysplasia, moderate dysplasia, or severe dysplasia. If it is cancer, which grade it is? It is well differentiated, it is moderately differentiated, it is poorly differentiated. Based on that, you need to do the specific treatment. So, whether the lesion disappears or whether lesion persists. If the lesion persists, what should be your next management protocol? Okay, now I will go briefly into the important clinical features or some important clinical points of each of these OPMD. Like, for example, leukoplakia, if you take the first one, that too homogeneous leukoplakia. Most commonly you see that in the any mucosal site you can see, but most commonly you see it in buccal mucosa. Usually it appears as a white patch which is non-scrapable. You can't scrape. Leukoplakia can't be scraped. it might be dysplastic or it might not. It might be non-dysplastic also. So remember, a leukoplakia, homogeneous leukoplakia, can show dysplasia or might not show dysplasia. Usually it is more common in men above 40 years and malignant potential is low here. So homogeneous leukoplakia malignant transformation is very less. Usually it is around less than 1% actually, they say. That means if 100 patients are there, only one patient will develop into oral cancer. That is homogeneous leukoplakia. On the other hand, there is something called as non-homogeneous leukoplakia or erythroleukoplakia, where you see white patch as well as red patch combination. Here, chances of dysplasia is more here. And malignant transformation is also high. Malignant transformation is also very high. We have another called as PVL, proliferative verrucous leukoplakia, which can occur in any multiple sites. It can occur on gingiva, it can occur on buccal mucosa, it can involve alveolar ridges, it can involve tongue. This is another OPMD, where again this will be usually white patch. Remember, the importance of this is it has got a very high, I should add the word very here, very high malignant potential. They say average malignant transformation rate of PVL is 70%. That means if 100 cases are there, 70 patients will develop oral cancer. So PVL is such a, you can say, a risky OPMD. Okay, so always remember PVL typically occurs in women above 60 years of age. Women above 60 years of age, where HPV has been implicated. HPV has been implicated in its etiology. Okay, then let us move on to anything else. Yes, erythroplakia is there, where it is just a red patch, completely red patch. Okay, again this erythroplakia will show dysplasia. Erythroplakia will definitely show dysplasia. Sometimes it can show even carcinoma in situ. Carcinoma in situ. What do you mean by carcinoma in situ? If dysplasia affects the entire thickness of the epithelium. We know epithelium has got 4 layers: stratum basale, stratum spinosum, stratum corneum, stratum granulosum, stratum corneum. If all the 4 layers are affected, you call it as carcinoma in situ. Remember again here, malignant potential is very high. Very high. But it is less than PVL. Malignant potential is not that much as that of malignant potential is not as that much of that of the PVL. Moving on to lichen planus. We have one type of lichen planus called as erosive lichen planus, which is a potentially malignant disorder. This more commonly occurs on buccal mucosa. Again, common in women, and its malignant potential is very low. Not so much. Not so much. What about OSMF? Oral submucous fibrosis. Yes, Again, it is a potentially malignant disorder where typically seen in Asian population. That is why WHO has called this disease or named this disease as Indian's disease, because it is so common in Indian population. Because of aracanut chewing, it is called as Indian's disease. Now let me summarize the clinical features of this OSMF. Usually, initially, in the early stage, if a patient comes, what will be the complaint? The most common complaint will be burning sensation. They say in the oral cavity they will have burning sensation. Normally, everybody will have burning sensation on eating some spicy food or hot food. But these people have a very high level of burning sensation. As soon as they keep something hot or they eat something spicy, they will have very severe burning sensation. So that will be the early initial symptom. So if a patient comes to you with a symptom of burning sensation, that should be an early case of OSMF. Then what the patient develops? Next patients, you don't treat that patient. You don't diagnose that patient. You don't treat that patient. After a few months, patient will come to you with the next complaint. What will be the complaint? Trismus. That is inability to open the mouth. Mouth opening reduces. Tongue protrusion reduces. See, all of us can protrude the tongue. Okay, we can throw our tongue outside. But these patients of OSMF, their tongue protrusion reduces. Still more, you don't treat these patients also, then the patient can develop ulcer or eMedicoz. So the symptom varies. Initially it will be different, later stages it will be different. Similarly, sign, what will be the sign? Sign is what the doctor elicits. Symptom is what the patient tells. What will be the initial sign? Initially, if a patient comes to me, what I will see initially in OSMF? I will see blanching. Please remember, this is very important. What do you mean by blanching? The mucosa becomes pale, totally pale, very light color. Normally, our oral mucosa is pinkish to reddish color, slightly red. But in these patients, it will be blanched. So looking at the mucosa itself on inspection, I have not touched the oral mucosa still. Through my naked eyes, I can see that the mucosa has become pale. Yes, this could be a patient of OSMF. Later, on palpation, I can feel the bands, because in oral submucous fibrosis, fibrous bands are palpated. Uvula can become shrunken. Patient can complain of dysphagia. Okay, difficulty in swallowing. Later, the patient can develop malignant ulcer or growth, which you can see. So blanching being the initial sign. Later, bands can be palpated, uvula changes can be seen, the swallowing problem can develop. Later, the patient, still if you don't treat, can develop the growth or ulcer. Growth or ulcer. Okay. How do you grade OED? OED is oral epithelial dysplasia. Now we know that these lesions, whatever we have discussed, let it be leukoplakia, erythroplakia, erythroleukoplakia, lichen planus, OSMF, PVL, all these will show dysplasia. All these will show dysplasia. Now dysplasia will have architectural changes as well as structural, cytological changes. That means architectural. Under the microscope, what will I see? I will see irregular stratification. Irregular stratification. I will see loss of polarity of basal cells. I will see bulbous retroedges. I will see increased number of mitotic figures. Please underline this. Number of mitotic figures is increasing. Like in one field, I'll be able to see 4 or 5 mitotic figures. Squamous, that is keratin, last class we have seen, keratin pearls. Loss or premature keratinization in one cell, or loss of cell adhesion or cell cohesion. Normally cells are connected to one another. If cells are lost, they lose their connection, that itself again is an architectural change. So there are so many architectural changes given by WHO for oral epithelial dysplasia. Now what about the cytological changes? Some cytological changes include abnormal variation in nuclear size. Nuclear size. Some cell will have big nuclei, some cell will have small nuclei. That is called as abnormal variation in nuclear size or anisonucleosis. Abnormal variation in a nuclear shape. Suppose a cell in one nucleus can be spindle shaped. Some cell can have spear shaped nucleus. Some will have ovoid. Some will have elongated. This is called as nuclear shape is changing. Different cells is having different shape of nuclei. This is known as nuclear pleomorphism. Nuclear pleomorphism. Similarly, cell size can be different. Cell shape can be different. There can be increased nuclear cytoplasmic ratio. Normally, nuclear cytoplasmic ratio is nucleus will be only one portion, cytoplasm will be 4. That is called as nuclear cytoplasmic ratio. Here it can become 1:1. That means nuclear component increases so much that the ratio becomes same. Nuclear cytoplasmic ratio becomes same. Normally it is 1:4. Atypical mitotic figures can appear. Nucleoli can increase in number. We know that nucleus contains nucleoli, and that nucleoli number as well as size can increase. Hyperchromasia can be seen. Hyperchromasia. What do you mean by hyperchromasia? Dark nucleus. I am able to see such a dark blue colored nuclei. I will call that nuclei as hyperchromatic nuclei. Chroma means color. Hyper, increased intensity. Nuclear intensity, color intensity increases. That is called as hyperchromasia. So these are some of the architectural changes and cytological changes that you should see in a dysplasia. Now I'll just skip this part, or I'll cover very fast. What are the molecular alterations? Not that important, but one of the some important point among that is LOH. Loss of heterozygosity. What do you mean by loss of heterozygosity? Chromosome will have certain areas called as loci. In that area, there will be LOH, loss of heterozygosity. That means that area will be defective. So you see such defective, then you call it, then that can develop into OPMD. So that defective loci can contain certain important genes like P53, or already I have discussed CDKN2A. These are important genes. If these genes are defective, then what happens? Patient will develop OPM. So LOH is at the chromosome level. Chromosome will contain what? DNA. DNA will contain genes. Okay. So LOH of certain areas of the chromosome which contain some important genes. What are those genes? P53, CDKN2A. These are the important genes which are defective. Okay, I'll not go much more details of this. Okay, what I'll just next go to the important part, that is therapeutic strategy. How are we going to treat these patients of OPM? What will be the first step? If any OPMD patient comes to me, what will be my first modality of treatment? I will try to reduce the inflammation first. That means how the inflammation will reduce? If a patient is a tobacco chewer, I will first counsel the patient to quit the habit, because tobacco chewing will reduce. If the patient quits the habit, inflammation reduces. Now, in spite of this also, you have counseled the patient, patient has quit this habit, and you have given the patient certain medication still, but still if the lesion persists, what will I do? I will surgically excise that lesion. Now, there are certain modalities of lasers. They don't use scalpel, rather they will use lasers. Carbon dioxide lasers are available, diode lasers are available, argon YAG lasers are available, ND-YAG lasers are available. These are certain lasers which are used because lasers have got a very greater advantage nowadays. They will reduce the pain, swelling is reduced, bleeding is reduced, rather than scalpel. Okay, so the excision of the lesion is the most important one. Another modality of treatment is followed nowadays, PDT, photodynamic therapy. What this photodynamic therapy will give? It will release singlet oxygen molecules, that is free radicals, free radical remover. Okay, I'm sorry, free radical remover. So these singlet oxygen can result in the regression of these such lesions. So PDT is again one of the modality of treatment that is used. This PDT is also used for fungal lesions, fungal infections. Okay, photodynamic therapy, which releases singlet oxygen species. Just remember that. Now, what is the another modality? Chemoprevention. Chemoprevention. What do you mean by chemoprevention? Patient has come to you with some white patch, some red patch. Something is there, white patch, red patch are there. What you will do? You will do chemoprevention. What are you going to prevent? See, the name itself is telling chemoprevention. You are preventing something. What you are preventing? Developing the oral cancer. Patient is having white patch. We don't want the patient to develop oral cancer. We want to prevent the development of oral cancer. Using what? Using certain chemicals. Here, chemicals means vitamins. Vitamin A and vitamin E are considered to be two important chemopreventive agents. They will develop or they will prevent the development of oral cancer. So if a patient of OPMD is there, which are the vitamins you prescribe? The most important one is vitamin A. Please remember this. Vitamin E again is synergistic. You have to give vitamin E in combination with vitamin A. Okay, so that is very important. You have to remember that is called as chemo prevention. Okay, now if a patient of low risk leukoplakia is there, low risk leukoplakia. What do you mean by low risk leukoplakia? We have already discussed leukoplakias which are low risk, like homogeneous leukoplakia. They are low risk leukoplakia. In such patients, what we need to do? See, we need to do first of all is counseling. Then we need to do dietary modulation. Like we need to tell the patient to consume more of green leafy vegetables, approximately 75 grams every day. Green leafy vegetables they need to consume. Green leafy vegetables, how much grams? 75 grams. We can give even antifungal drugs like clotrimazole. 1% clotrimazole can be given for 7 days. Vitamin A has to be prescribed. What I have told you, vitamin A, very important vitamin A. So remember the dosage of vitamin A. 25,000 international units has to be given twice daily. That too for 3 months, 90 days. This is called as essential treatment. This much I definitely have to give. Counseling, modulation, dietary modulation, antifungal drugs, vitamin A. Optimal treatment. What should be my optimal treatment? Optimal treatment is curcumin. This is a very important one. You have to remember curcumin. What curcumin will contain? Curcumin is a root, okay, which will contain the turmeric extract. That is why in Ayurveda they say that turmeric, that is haldi, should be used because they contain antioxidants, and that curcumin, which is an extract of the turmeric, is given in the dosage of 600 mg. That too 3 capsules 2 times daily for 6 months, because curcumin will contain antioxidant. This is what we do for low risk. Now what we do for high risk leukoplakia? If a case of high risk leukoplakia is there, we will, rather than all these measurements, we will go for more advanced treatment like surgical excision, lasers, photodynamic therapy. All these are certain advanced way of treatment in case of high risk leukoplakias. Now here, what this photodynamic therapy will use is, it will use aminolevulinic acid, either 10% or 20%. Aminolevulinic acid is used either 10% or 20% in case of the high risk leukoplakia for PDT. PDT is photodynamic therapy. Now what is the treatment modality for OLPs? OLP is oral leukoplakia. If a patient of oral leukoplakia is there, that too with dysplasia, I will use triamcinolone acetonide. Triamcinolone acetonide. Triamcinolone acetonide comes in the trade name called as Canacort. I'm not marketing the drug here. Why you should remember this trade name is it has become so common or so widely used. MCQs have come using this as an option. Canacort. 0.1% Canacort. That means 0.1% triamcinolone acetonide. Or you can use other steroids like clobetasol. These are steroids. Triamcinolone acetonide is a steroid. Clobetasol is another steroid that we can use it. So whenever a patient of oral leukoplakia oral lichen planus patient is there with dysplasia, we need to give steroids. However, in case a non-dysplastic leukoplakia is there, there are other ways of treating this patient. Like usually what they do is they follow up these patients. If there is a non-dysplastic oral leukoplakia, they will follow up these patients. Follow up what? You need to follow up for these patients whether they will develop any changes. If they develop any changes which you can see through the naked eye, you can do a biopsy from that area. And if the biopsy will show dysplasia, then you need to change the treatment modality. Okay. So to summarize the entire lecture, what is potentially malignant disorder? It is a group. It's a group of oral mucosal lesions where there is increased risk of oral cancer. Can you tell me some examples? Yes. Leukoplakia, erythroplakia, oral submucous fibrosis, oral lichen planus, syphilitic glossitis, proliferative verrucous leukoplakia. All these are examples. Okay. Now, exactly what should be the? Can you see do you see dysplasia in all OPMDs? No, it's not mandatory. There are some OPMDs where there is no dysplasia. Okay, where there is no dysplasia. In such cases, you diagnose these as hyperkeratotic lesion. Okay, I'll just take 5 more minutes and explain what is this concept. Very important, please pay attention. There is a patient named X. This patient comes to you with a white patch on the buccal mucosa. Okay, you will see through your naked eye there is a white patch on the buccal mucosa. But one part of this white patch, one corner, there is dysplasia. But rest 90% of the white patch is not having dysplasia. Now question comes, can I see dysplasia through the naked eye? No. Dysplasia can be seen only under microscope. Now, does the surgeon has microscopic eyes? No. Then, if I do a biopsy from this area, where there are no dysplastic changes, I will give a wrong diagnosis. What will be my wrong diagnosis? I will say that this is a leukoplakia without dysplasia. But at one corner of the white patch, there are dysplastic cells. If the surgeon will diagnose or do biopsy from that area, I can say that this is a dysplastic tissue. Now comes the question, how should I see those dysplastic cells? There is a chemical called as vital stain. Vital stain, that is toluidine blue stain. The name of that stain is very important, toluidine blue. What this toluidine blue will do is, patients comes to me with a white patch, I will use this stain and apply entirely with a brush entirely on the white patch. I will make the patient to wait for 10 minutes. After 10 minutes, I will ask the patient to rinse their mouth. Okay. In the entire white patch, some area will remain bluish. All the other area will become white. The part which has taken this toluidine blue is nothing but the dysplastic area. So surgeon has got an idea. Yes, after vital staining, this area is dysplastic. I can do biopsy from this area. So now, after doing a biopsy from this area, the pathologist can give a diagnosis that this is dysplastic tissue. This is a dysplastic tissue. So that is the role of vital stain. Again, this vital stain very frequently asked as an MCQ in various entrance examination. Okay. Now we have already completed the treatment modality for different types of OPMD. For oral leukoplakia, it is different. For OSMF, it is different. For lichen planus, it is different. Okay. I hope you have understood this concept of oral potentially malignant disorders. We'll keep on updating you on this platform for more such lectures. And then any doubts you can ask me. Okay. Otherwise, we will stop here and then we'll continue with the next lectures in the coming time. Thank you so much.